You can start, sir.
Okay. करू चालू ना कुलकर्णी सर?
Oh, करो चालू.
Okay. I welcome you all on behalf of IAP Pune for this webinar on TB updates. Every year we observe 24 March as a World TB Day. This day is the date is marked the day in 1882 when Dr. Robert Koch announced that he had discovered MTB, Mycobacterium TB. So this year's theme of World Tuberculosis Day is Invest to End TB and Save the Lives. So interestingly, we have seen that mortality is increased in 2020, and we'll discuss about it, the updates and some epidemiology. So I request Dr. Deepak Mole, Secretary, Indian Academy of Pediatrics, Pune branch, to introduce our faculties.
Thank you, Parag. Thank you very much. Welcome all. Good afternoon. Welcome, Dr. Pramod Kulkarni, sir. He will be today's moderator. Welcome, Dr. Sanjay Mankar, sir, and welcome, Dr. Bane, sir. Piyush, please, हे करता slide. Dr. Pramod Kulkarni, sir. He is a pediatric infectious disease consultant at KM Hospital and Dinanath Hospital. His special interest is pediatric infectious disease. He is the secretary of IAP Pune 21. And his book chapters are Rational Antibiotic Practice in Pediatrics, Pertussis Surveillance Study, WHO IAP COVID Registry, IAP Modules, EPID, LEID, RTI, GEM, PGU Education. Next. Next. Dr. Sushant Mane. He is a MD Pediatric Associate Professor in Grant Government Medical College, JJ Group of Hospitals, Mumbai. He is a Nodal Officer, State Pediatric Center of Excellence for Tuberculosis. He is in charge of Pediatric Asthma Clinic. He is a member of National Technical Experts Group, NTP India. He is Associate Editor, Journal of Pediatric Pulmonology, National Respiratory Chapter, IAP 21. He is a national trainer for asthma training module, TB module, and many other modules. Numerous publications in national and international index journals. Next. Dr. Sanjay Mankar, sir, he is a practicing pediatrician at Simhagad Road, Pune. He is a professor in pediatrics, Bharati Vidyapit Medical College, Pune, Maharashtra. He is a consultant in pediatric infectious disease, and he was IAP Pune President 2019. Over to you, Pramod Kulkarni, sir.
Thank you very much, Deepak. Good afternoon, everybody, on this hot afternoon. The discussion is also going to be about a hot topic. The recently concluded World Tuberculosis Day. Everybody has seen the propagation of the information and the updates to the medical practitioners about the tuberculosis. And in the same context, we are conducting this short CME. Dr. Vijay Yavale, he promised, but he had some preoccupation.
Sir Yavale, sir, joined.
So if Dr. Vijay, you are here, you are most welcome to participate and guide us about that.
I'm in the meeting. I would like to listen to you.
That's absolutely fine, sir. And I'm very glad that we have got real hands-on experience and master expert, Dr. Sushant Mane today, who is a nodal officer at Mumbai. And he is the real authority to teach us about the current trends, changes, and updates of tuberculosis. Welcome, Dr. Sushant Mane, a well-known pulmonologist and TB expert, and who is the real authority. I also welcome Dr. Sanjay Mankar, who is again an ID expert, and let me say that he is representative of all pediatric practitioners with an ID view and ID expertise as well, who will be contributing to this discussion richly. So let's start the discussion with, I have got a short presentation to go through, and my faculty are requested to just keep on commenting and saying while these slides are being displayed. Is my screen visible?
Yes.
Yes, sir. Yes, sir.
Yes, sir. फक्त full screen करा.
Is it now?
Yes, yes,
Oh.
yes, yes.
So let's start. So childhood TB updates, why we should, practicing pediatrician should be updated about childhood tuberculosis, because there are epidemiological changes in TB over last 2 years since the COVID-19 pandemic. There are significant changes in recommendations and guidelines, definitely for everybody of us. There is rapid development of diagnostic tools and techniques, which are incorporated into practice. Social and regulatory necessity in pediatric practice. We all must be aware we have to legally report all the TB cases which we come across, we diagnose. And more than this, a broader target. We are nearing the national and global goals of TB elimination. That is WHO in TB strategy, reduction in TB incidence by 80% and TB deaths by 90% to be achieved by the year 2030. And our personal national commitment to 2025 as the preponed goal by our respected Prime Minister. So how to get these updates? Let us revise the NTP IAP training, which is a must for every practicing pediatrician, and that is the gold standard. Apart from that, we have online resources on TB, which can be explored, read, and very well studied, which are available on IAP website, WHO website, Central TB Division of Government of India, and IUATLD. Let us review and research journal articles on Google Scholar and PubMed also update us about the tuberculosis happenings. And CMEs and physical online this is going to. The biggest news, the biggest update here, the release of WHO consolidated guidelines on TB, specifically dedicated to management of TB in children and adolescents, was released just few days back on 22nd March of 2022. And I'll request everybody of you to get it free, downloaded online from WHO site, which is freely available and which is the gold standard on which we have our NTEP program based and with local customized inclusion of the recommendations. Am I right, Sushant?
Yes, sir.
So today's goal, review burden of TB in children, updates about NTP recommendations and guidelines, updates about diagnostic, updates about therapeutic changes, and update practice point. Let's go ahead. This is the typical cascade of TB care in children. Exposure, infection, disease. There are many points where the child can be picked up at various stages and subjected to appropriate action after appropriate screening for infection disease for treatment or preventive treatment. So let us go for epidemiology updates. Sushant, may I know what are the latest trends in TB over the last few years, especially after the COVID-19 pandemic?
So what happened in 2020 was the COVID pandemic started. So the pandemic started in India around end of February and March. So till that time, the reporting of TB cases was happening very regularly. And in fact, it had improved over the past 2 years. So if we see the record of 2018 and 19, as compared to that in 2020, the reporting of TB was improved. And initially, there was always a thinking that private pediatricians or private practitioners are not reporting cases, but even this number had gone up as far as 2020 initial part and 2019 was concerned. Now, what happened during pandemic was during 2020, suddenly the lockdown came, okay, and everything was shut down. And therefore, there was almost a 40% decrease in the reporting of cases, which happened in 2020 till the end of 2020. And this is not only in India, it happened all over the world. Wherever, there are the TB incidence and prevalence is high, it was seen that around 40 to 42% reduction in the reporting of TB cases was seen. And because of this, what has happened from the beginning of 2021 is we are seeing an upsurge of cases. So it is not only in the public sector, but also in the private sector, especially where we are there in Mumbai. And it is there all throughout the country also, that people are reporting that we had not seen so many TB cases in 1 year in our private practice, but now in 2021 we are seeing. That is because what happened was, during COVID pandemic, though people were symptomatic or though people had symptoms, they could not go out. Okay, because there were lockdown, there were restrictions. That is the first reason. It is not that the program had shut down, program was functioning, but then people didn't have means to travel, because in the initial 2 to 3 months there was a complete shutdown and people were only allowed to go out if there was a medical emergency. So that led to people staying indoors. Now that is one reason, that people who were infected, they were not able to go and seek medical help. Now, as we know, during lockdown, in many places, in small houses or small areas, there were too many people staying together. So if there was 1 or 2 index cases in the house, because of the close proximity, that person has spread the disease to the other people who were staying inside. That is the second reason why in 2021 we are seeing upsurge of cases. One, those who were already diseased, they came out in 2021. Second, because they were confined indoors, they were spreading disease to the others, which are very close. Third is, as we know, in India, the incidence or the background prevalence of latent TB or TB infection is around 44%, which is highest in the world. So 44% of our community actually has latent TB infection. Now, again, what happened, because in 2020, many of these middle-aged and elderly people who had latent TB got admitted to the hospitals because of COVID-19, because they had contracted COVID-19. And in spite of repeated literatures and warnings, all the immunosuppressants like steroids and tocilizumab were used unrestricted, and sometimes when they were not indicated, which has again caused the latent TB infection to flare up. So, these are all the reasons why in 2020 we didn't see so many cases, and in 2021 the cases have gone up. So there was a paper which was published in March 2021, which they did a epidemiological study all over the world from areas which reports from areas where TB is reported in high prevalence. So what they have by logistical analysis, what they have postulated is that because of these lockdowns which were there, we have actually went back 3 to 5 years in our fight against TB. And in the upcoming 5 years, from 2021 to 2025 or 26 year, we would actually see increase in the number of cases and increase in the number of deaths.
Sushant, very well said. So what are the concerns, and how should we research from this problem of COVID-19 affecting the TB and sending us back by a few years? So what really a practicing pediatrician should do or contribute to this catch-up in the TB elimination?
So as
Sushant and Pramod, can I come in at this point of time?
Please.
Yeah, I absolutely agree with what Sushant said. However, in Mumbai also, we have seen a lot of increase in number of cases of TB, both drug sensitive as well as drug resistant TB. One of the reasons cited is overcrowding and people staying in small slums and overcrowded area. One went undiagnosed, and those who were diagnosed defaulted, and they went on spreading disease. However, Sushant, my question to you is, have you seen number of family members coming with tuberculosis? What we saw, we have seen a surge, but not that more than one member of the family, coming with tuberculosis. So what is your comment on this?
Yeah, we have seen that in the past 6 months, from I can say Diwali 2021. So when we diagnosed one case, we have seen quite a number of cases where the mother was having infection and then the children have got. That was what we have seen, or mostly, especially in slum areas of Mumbai, when there are joint families or staying. Okay. Or a close neighbor is there who is staying actually in the house and they have got. So this is seen in the last 5 to 6 months.
I'm sure Pramod will take this up later, but I may have to leave in between. Another question is, how aggressive are we on contact tracing, both in private sector and in the program? That is lacking.
And that needs to be built up. Like what Pramod sir was saying, what are the concerns for action? So first thing what sir said, it is time that general pediatricians don't consider TB as a specialist disease, and TB alyavarti just refer the patient. No, we all must get updated at least by the IAP and NTP guidelines, which are very simple to follow. And we should all be in a position to manage drug sensitive TB. That is one thing, because whatever we are seeing, drug sensitive is also going up. And second thing, as what Yavle sir said, whenever we have diagnosed one case of TB, we have to go after the family and screen at least all the people who are staying inside the house, which still lacks. Because you're running a center at JJ, Center of Excellence, what happens is we get referrals. But when we see the child has been started on treatment since 15 days or sometimes 1 month or 2 months, but still no family screening has been done. So that is where it is lacking, and we pick up patients if family screening is done.
Dr. Sanjay Bankar, have you observed such a change in Pune area also, as you work both in private as well as in an institute, teaching institute?
Yes, definitely. As Sushant sir has rightly pointed out, we have a lot of patients with latent tuberculosis. So after the epidemic of the COVID, there is definitely rise in all kinds of tuberculosis. We are seeing pleural effusion with the tuberculosis. We are seeing abdominal tuberculosis very commonly, lymph node tuberculosis very commonly. Since the latent tuberculosis is very common in the pediatric age group, the incidence is almost more than 30% in a pediatric population. Definitely there is upsurge in all the cases which are seen. And as sir has rightly pointed out, most of the people in adults, they are giving a lot of immunosuppressive drug, including steroids are being given, and the adults are first suffering from the tuberculosis, and then the family members, especially kids, are also suffering from the tuberculosis. We have not come across that much amount of drug resistant tuberculosis in Pune, but we are definitely seeing more amount of drug sensitive tuberculosis in Pune still.
So we come back to the same line again. The adults who are being over-treated with immunosuppressants become the target of tuberculosis, and yes, they spread the disease to children who are otherwise not very seriously affected by COVID infection as such. But still, everybody of us must be on toes and with our antenna sharpened to pick up more cases of TB and more disciplined in reporting them appropriately for appropriate action.
Even, sir, here I would like to say, even in children, though they are not having serious COVID, what we have seen is, misdiagnosis of MISC, and again, steroids are given unnecessary for all fever patients.
Absolutely. Definitely, that is an area where the steroid treatment has become little loose kind of action by pediatricians. So this is about the burden of TB, global TB, and TB in India also. These are just mind-boggling numbers, and we are still in very bad state of tuberculosis infection all over the India. This is the global status. You will see the biggest orange circle is on India. So again, almost 11% of the tuberculosis cases are less than 15 years. And 50% of them are less than 5 years. There is a big detection gap. So more than 50 to 60% of the pediatric TB cases are not reported in National Tuberculosis Program, including India. And that's a very sad story where we have to be up and very alert and very proactive in doing this, because unless we do it, we are not be able to control the future population of adult tuberculosis. Only 1/3 of the contacts of TB cases, they get a tuberculosis preventive therapy. That's again a very bad figure to watch at, and we are party to all this thing. The onus is on to us. So about 500 million adolescents, which actually belong to 15 to 19 years, but they come to a pediatrician for management. That also forms a sizable number of tuberculosis patients or infection cases where we had to be very, very alert. This is about the burden. Now, this is about the hurdles of childhood TB control. We all know possibacillary disease, extrapulmonary disease is more predominant, non-specific presentation, specimen access issues, lack of sensitive POCT, and everything, and poor reporting TPT rates. That is more important. These are all the reasons and big hurdles in childhood TB control. Now, let us come to tuberculosis screening. When to suspect tuberculosis? That is the typical one we start with. Dr. Sushant, can you please enlighten us about, and we have the recommendations of latest WHO recommendations with us.
So what even the WHO or even Indian guidelines say is, if we have one index case in the family, especially who is a case of pulmonary tuberculosis, because pulmonary tuberculosis are one which are considered to be infectious and potential spreaders. So they can be either sputum positive or sputum negative. That is not the issue, because many of the pulmonary patients who are sputum negative eventually turn out to be positive on culture. So any patient or any index case with pulmonary tuberculosis is detected, all the household contacts first, which are there in the house, are to be screened, and then the close contacts. And screening, when we say it is a symptom based screening, that means we see the cardinal symptoms of tuberculosis in the contacts. If the patient has particular signs and symptoms suggestive of TB, then we go ahead and do a radiological test like an X-ray and gene expert, depending upon the case. But the thing is, everybody has to be screened, and that is a very strong recommendation in any guidelines which we see.
Yes, so what is most important is systematic screening of a suspected case or presumptive case is very, very important. And household contacts and other children at risk, that is very important. And how to do this screening? Again, as you said, Sushant sir, can you please elaborate with this?
First is symptom screening. We have to see for cardinal symptoms of TB. If any contact is having fever for more than 15 days, cough for more than 15 days, loss of weight or not gaining weight over the past 15 days, or there is a weight loss of more than 5% over the past 3 months. So any of these symptoms are present. That is, these are symptoms which can be seen in pulmonary TB or even in extrapulmonary TB. That is your fever and not gaining weight or weight loss. Apart from that, if we think of extrapulmonary TB specifically, the commonest being lymph node TB. So any swelling anywhere in the body which is being there for a very long period of time without signs of inflammation, any chronic low back pain which is not relieving by our normal painkillers or what we take, or any other symptom which should not be there in the patient. And if there is a strong history of contact with the TB case, we should be suspicious that these are symptoms of TB. Once these are there, what we do, the first investigation which we do is a chest X-ray, because whenever we talk of infection or infection entering into the body, it is always by the route of respiratory system or lungs. And then depending upon what X-ray suggests, we go ahead with further investigation. So if the X-ray is suggestive of tuberculosis, that is, we have hilar or mediastinal lymphadenopathy, we have a miliary pattern, or we have a cavity or something like that, then we go ahead and do the molecular test, that is our gene expert and all. So basically screening is first symptom screening, and depending upon the symptoms, chest X-ray, and then the algorithm goes forward how to do and what to do in the patient.
Dr. Mankar, we have given options of all these. This is of course a clinical score or a starting point. So do we have, we solely, most of the cases, we read a microbiological diagnosis is not possible and not positive as well, even if we work up. So in that case, we have to revert back to clinical symptomatology as one of the diagnostic parameter. In that case, do we have any rating of all these symptoms alone or their combination or the radiological? So one symptom against two symptoms against three symptoms plus radiography plus history of contact. So more number, does it really help in going towards diagnosis?
Yes, as far as possible, we try to do a microbiological confirmation of the tuberculosis. It has to be done with all possible investigations whenever they're available, and presumptive diagnosis should be avoided. But when the microbiological confirmation cannot be possible or has been tried and still the symptoms are suggestive of tuberculosis, we can definitely make a diagnosis of tuberculosis. Like suppose the child has got X-ray which is suggestive of tuberculosis, he also has a signs, he also has a weight loss, he has a night sweats, he has a loss of appetite as important features, and you think that this can be a tuberculosis, then all the effort should be made, like gastric aspirate samples, and now the new recommendations are to send them for the ultra gene expert rather than the previous gene expert. So we should make all possible efforts to send ultra gene expert. Previously we used to send gram stain, Zn stain also. So slide confirmation is also done. All these tests should suggest whether it is a tuberculosis or not, but if not, then the presumptive diagnosis also can be made for the tuberculosis.
Very well said. Again, to increase the pre-test probability of tuberculosis diagnostic test, we do this clinical screening. So the chances of getting positive results are more and wastage of resources is less. So this is the important starting point when to suspect tuberculosis. Now, coming to tuberculosis,
Pramod, can I come in again?
please, Vijay.
IAP NTP module talks about TB suggestive X-ray as lymphadenopathy, mediastinal lymphadenopathy, and the miliary shadows and cavity. If you look at the WHO guideline, they have categorically included pleural effusion, pleural reaction also as one of the features suggestive of TB. Sushant, would you agree with me?
Yeah. Yes.
So, because why I'm bringing this up is for a clinician, establishing a microbiological diagnosis as such in pediatric is a challenge. However, we have seen that with the increasing use of gastric aspirate and induced sputum, very often we are rewarded with a positive diagnosis. However, what continues to remain most challenging is pleural effusion in clinical practice. So it is very, very difficult to establish a microbiological diagnosis. However, pleural effusion has been included as one of the TB suggestive feature on X-ray, even in the WHO guidelines.
So as per our previous ATP, these were only 3 patterns, and now we have addition of pleural effusion, as Dr. Yevle says. So we have now 4 typical patterns highly suggestive of tuberculosis now for clinical diagnosis of tuberculosis. Yes, that is big addition, and thank you very much, Dr. Yevle, for that. So now another change, Dr. Sushant, we are focusing towards specific microbiological diagnosis. That is the first target of any pediatrician looking at a possible case of tuberculosis for treatment. So we are already gone through the era, and we are very well versed with CBNATs now. So what are the latest updates about this CBNAT and the next technological advances?
So the original CBNAT, which is there, that is our gene expert, it still remains. So what WHO says is the first point of care test or the diagnostic test which we should use after an X-ray is a CBNAT. That is our gene expert. Now, gene expert ultra is recommended especially for cases like pediatric TB or extrapulmonary TB like a pleural effusion or an ascitic fluid where the disease is paucibacillary, and because ultra picks up lesser load of bacteria, it is highly sensitive. The specificity of gene expert and gene expert ultra is same. The sensitivity ultra has a more higher sensitivity. Now till 2022, ultra WHO recommended gene expert ultra to be used in specimens like sputum and nasopharyngeal aspirate. That is, those were the 2 samples which were approved. Again, it was a moderate level recommendation. Okay, but in these guidelines which are released in March 2022, just few days back, they have now recommended, especially in pediatric age group, ultra can be used for a gastric aspirate, which we do commonly, and also for a stool specimen. So what literature review which we did during framing these guidelines, we saw that the sensitivity of using expert ultra in a gastric aspirate and stool is somewhere in the range of around 60 to 63%. So it is quite good. So 60 to 63% is a good sensitivity, and specificity is again higher to the tune of more than 70%. So now they are recommending that if it is very difficult to obtain a sample, like in pediatrics, even a stool, because stool sample does not require a great technique to collect. Okay, the mother can be given the falcon tube, the mother collects the stool and it goes to the lab. The only thing is the lab should be equipped to process the stool, because getting a test done on stool, it is a little cumbersome, because they need to do flocculation, sedimentation, centrifugation of all the stool samples. Then they take the supernatant and then they put into the gene expert machine. So the labs have to be equipped to handle stool samples. Nevertheless, what they say is, if we get a stool sample and if it comes positive, it is considered as a positive diagnosis. It has a very good positive predictive value, but it does not have a very negative predictive value. That means if a patient is showing signs and symptoms of TB, it is highly suggestive of TB. And if the stool gene expert ultra comes negative, then we have to repeat maybe a gastric aspirate or a invasive sample like a BAL to get a diagnosis. So it has a very good positive predictive value, but not a negative. So if it is negative in a highly suggestive case, we may have to repeat it on a sputum sample or a BAL sample.
So it's quite attractive to have a sample, convenient sample like stool, yes, and getting a diagnosis of TB, especially in pediatric. Have yes, you really started doing stool samples for ultra at your place at government setup?
Yeah, so we are doing, JJ has a national reference laboratory. So we are doing the stool samples as a part of our operational research. At present, the national program has not incorporated stool ultra, because ultra also is not being made available at all the centers. It is only available at selected centers. So right now in our national program, we do not have the facility of using stool ultra. But if we have the facility in a private lab, who is a well accredited lab and who is a lab which is accredited by the national program, that is NTEP. Like in Mumbai, we have 2-3 labs. We have Hinduja Hospital, we have Metropolis, we have SRL labs, which NTEP has certified to be, valid to conduct all these tests. So if we have that facility, yes, and if the patient is affording, we can send the sample. But then we should be very careful that the lab has to be certified by NTEP, because there are so many small scale labs which are doing all sort of random tests where the kits are not standardized, and then we are in the soup if we get erratic results.
Especially Dr. Bankar, we have been using ultra in Pune at many of the laboratories over the last 3 years. What is your personal experience about ultra? The initial problems faced by everybody of us, the very low or trace reports with RR indeterminate, and the clinician telling us, so especially the BAL samples or other samples which were very valuable and precious samples, and we had to take a decision with ultra telling us the report to be very low or trace. It was very difficult, and the clinician used to say, clinically, I'm not suspecting this is incidental finding. So what is your experience about this ultra and the problems related to that?
Definitely, expert ultra is highly sensitive, as Mane sir has said. It can pick up even up to 16 number of the bacilli which are there. So it's a highly sensitive way of picking tubercular bacilli, and it is definitely useful. We are using it, though it may show a low detection. As such, the tuberculosis in pediatric age group is a paucibacillary disease. So it may show very low level of this thing, and it may show indeterminate resistance, but that is fair enough. Once it is a positive, you can take it as a positive. Second thing, we don't recommend this for monitoring the treatment, because it's being very sensitive. It will pick up even the dead bacilli also, and we don't advise what this gene expert ultra for monitoring the disease as such, or making whether it is a become negative or what. So for that, the only sputum will be helpful.
Can I
Dr.
come in
Tushar?
here again, Pramod? Pramod, can I
Yes,
come in
please.
again?
Please.
Yeah. See, if you look at the sensitivity of ultra, 16 bacilli versus 130 plus in the regular gene expert. Now, it was a trade-off, sensitivity and specificity. Higher sensitivity was a trade-off against lower specificity. And Sushant, if you recollect, we used to say that ultra was specifically developed for paucibacillary pediatric disease,
That is what I said. Yeah.
extrapulmonary TB or children living with HIV. But issue is, as Pramod brought it out very correctly, in the past, many of us face the problem. So you subject a child to some scopic procedure, endoscopic procedure, and the report is to be positive. And then it was the trace call. There was a big WHO guideline on how to interpret and treat the trace call. And it was said that unless you have a appropriate pre-test selection of the patient, this trace call should be disregarded. What is there any change in the interpretation now?
No, it's still the same. We always have to look at the pre-test probability of the result, because we are getting so many results where it is very low and rifampicin resistance detected or trace and resistance detected. But then if there is no background at all to suggest a drug resistant TB, most probably this is an erroneous result which comes. And that is what happens even in gene expert, which the program says if it is very low, we have to repeat the test. Because what happens with a very low result, the test cannot read that rifampicin resistance very clearly, and that erroneous results can come.
Another question and input at this point of time is, in the beginning, we said that any resistance reported on your gene expert, not ultra, on gene expert, had to be confirmed by a repeat test. And last year in 2020, just at the onset of pandemic, there was a NTP guideline from the government. There was an advisory that even if you have a positive test, if you have one positive test, you treat it as drug-resistant TB.
Yeah.
What's change in this?
So now they say if the gene expert report says MTB detected very low, then only we need to repeat the test. Otherwise, if it is low, medium, high, we treat it as resistant and treat. That is what is followed right now.
So even gene expert, if it shows different, you treat it.
Yes, if it is low, you treat it.
Yeah, yeah. So that is one change which was brought in last year. Yeah, 2020.
So coming to tuberculosis diagnostics, for a practitioner, again, this is the scientific material and importance which everybody has to note. Leave apart the finer molecular techniques, the diagnostic role of a TB algorithm is the most important one. Dr. Sushant, can you tell us about some changes in the diagnostic algorithm recently done in NTP, and again the precision of this algorithm in management and diagnosis?
So this was again this is again a new recommendation in the WHO guidelines. So they are recommended for children up to 10 years of age. So there are two reasons, like we said. Number one, because it is possibacillary and it is very difficult to get a microbiological confirmation in children less than 10 years. And again, it is a big task to obtain samples from such children. Second, as we said right at the beginning of this session, the detection gap in children less than 5 years is very high. It is more than 50% or 60%. So considering these two reasons, what this recommendation, and this is a conditional recommendation. What do we mean by conditional recommendation is the countries have to review their own situation and adapt this recommendation depending upon the country specific situation. So what WHO says is that up till the age of 10 years, we should form a scoring system, like how we have respiratory distress scores or new Ballard score, something like that. So we should have a scoring system in place if possible. And depending upon the scoring system, we will give scores. And then on that scores, it is feasible that we can treat such patients on clinical grounds without having a microbiological positive report. But the disclaimer is we have to take efforts to have a microbiological confirmation. If we don't get a microbiological confirmation, we go according to the scoring system and treat. Now, as far as NTP is concerned, IAP, NTP, we already have a very good algorithm for diagnosis and treatment of pulmonary TB, which includes our clinical diagnosis also. So which says that if it is highly suggestive of TB, we have taken one sample, two samples, even invasive samples, and the patient does not fit into any other condition, and he has characteristic signs and symptoms of TB, it is justified that we can start this patient on treatment for tuberculosis, labeling it as clinically diagnosed TB or probable TB.
So again, it comes down to the same algorithm which we had, which emphasizes about repeating the molecular test with a better specimen. And the second one, without hesitation, which remains equally important. So once negative is not negative, try your best, get the best possible specimen. Many of the occasions we have seen the second specimen gives us positive result and we can go ahead with the treatment.
Most of the time what happens is, even if we don't get a sputum sample properly, if we examine the patient, many of the times, at least 30 to 40% of the time, there is a cervical lymph node which is sitting. So in the second attempt, it is always better that we don't again go in for an induced sputum or a gastric aspirate. It is better to take a sample from the node, which is very high chance to come positive because it is a tissue which we are sending.
So infected tissue becomes the better specimen, followed by your other sources where you get mycobacteria. Sanjay, what is your experience about need of repeating the microbiological test and its usefulness?
Definitely, sometimes when, like sir said, sputum is negative, we can definitely repeat some samples, like we can send gastric aspirate, or now the stool is also recommended. So you can send a stool for with the ultragene expert, and also definitely repeating samples will be very helpful for microbiology.
सर त्यांचा आवाज कमी येतोय खूप.
Can you hear me?
Yes, please go ahead.
मोठ्याने सर.
Okay. So definitely repeating sample will be helpful at a certain point of the disease. Definitely.
Sushant, do we have? Yes, please.
See, I cannot overemphasize the importance of looking at an alternate specimen. On n number of occasions, we have had patients of chest TB, pulmonary TB. Incidentally, now in WHO latest guidelines, it is very clearly mentioned that mediastinal and hilar lymph node disease is now considered as pulmonary TB, pure pulmonary TB.
Yes.
Okay. So, n number of times we have come across patients where you have TB suspicious X-ray symptomatology, and it is probable TB, but the sputum or a gastric aspirate is negative. What we do, we look at the peripheral nodes very, very carefully. And in private sector practice, in fact, we subject many of these children to sonography of neck. And invariably, you are able to detect a lymph node there. And you do lymph node aspiration or lymph node core biopsy, and you are rewarded with a positive result. So we must try and get a better specimen and an alternate specimen.
Thank you, Vijay, for that. Sushant, so are we expecting any changes, update of the algorithms in near future, which will include this stool expert as well as the clinical scores?
So stool expert, not very soon, because the problem with our program is logistics. Because if we want to start anything, it includes a lot amount of logistics, finances involved. So stool expert will take a little amount of time. But yes, algorithms definitely, if IAP body takes up, we can modify the algorithm. We actually have a pulmonary TB algorithm, which is there in the IAP and TP guidelines.
So again, we have seen this addition of the pleural effusion, as Dr. Yevle said, to these three classic presentations, radiological images highly suggestive of TB. That is mediastinal lymph nodes, the adenopathy, miliary tuberculosis, and thick-walled fibrocavitary disease. So now coming to Reef Ultra, and Dr. Sushant, can you highlight little on this Ultra? Now it has been established and taken up by WHO as non-inferior alternative to Gene Expert, and it's a standard inclusion then. What is your personal experience? You have seen many samples being processed with both the techniques. What is your opinion? Is it really better or more useful?
So like Vijay sir said, it is most useful for specimens where we expect that the bacillary load is going to be low. So if, for example, if we want to give an example, if we have an adolescent, say 12 or 13-year-old female or a male who is having a frank cavitary disease, there is no use sending an ultra, because we know that cavitary disease is going to have high bacillary load, and even our Gene Expert is going to come positive if we send a properly taken sample or properly induced sample. However, in places like CSF or ascitic fluid or pleural fluid, especially pleural, where it is a difficult to get specimen, or sometimes in the lymph node sample, if a FNAC specimen is considered, if we send a tissue biopsy or core biopsy, or if we send a pus, it has a rich load of organisms. But if we are sending just an FNAC, again, we don't know how much load of the organisms is there. So in such kind of samples, like a pleural or peritoneal or CSF or maybe a lymph node aspiration, ultra fares better, because of the only reason the sensitivity is high. Otherwise, specificity is almost the same or a little lesser, but because the sensitivity is high, it is useful for such. And of course, tool, as we discussed. So if facility is available, right now the program does not give it free ultra, but yes, if the patient is able to pay and the lab is there available who is doing the accredited ultra, we can use ultra for such specimens.
The important change or the advantage, what I practically see, it is about the TBM, where we have to send minimum 5 ml of CSF. In young infants, it's quite difficult. I think the Ultra has a claim that it can detect even with 2 ml of sample is sufficient for Ultra. Is it a fact?
Yes, even 2 to 3 ml sample is sufficient.
Yes, so that seems to be a great. So maybe next changes will get less quantity of CSF sample to be collected for Ultra will be included in the guidelines. So that is about Ultra. What about TST and IGRA? Sushant sir, please tell us.
Pramod, before Sushant talks about TST, let me tell you one thing, that it is a mindset that we get scared of collecting 5cc CSF. Because ultra may not be available everywhere, and still widely program uses Gene Expert. Invariably, patients who have meningitis, whether it is tuberculosis or otherwise, there is ample of CSF available, and it is not a difficult type at all. We somehow hesitate in collecting higher volume, and it is, whether it is blood or CSF or any tissue sample, higher the volume, better is the yield. So we should make it a point to send adequate quantity of CSF, because ultra is still not available everywhere.
So if you're sending Gene Expert, you have to send at least 5 to 6 ml.
So the recommendation remains the same, minimum 5 ml and maximum possible highest quantity of CSF or any body fluid should be sent for microbiological studies of tuberculosis. So Sushant sir, tell us about TST and IGRA. What is the current position or place in WHO recommendations, latest WHO recommendations?
TST and IGRA are both tests for detection of TB infection. So they are not recommended for detection of TB disease or active disease. So TST is the skin test. So what we saw, the initial skin test, what we were using is the Mantoux test. So if we have that Mantoux solution available, we should do it with a 1 TU or a 2 TU, maximum 5. You should not go more than 5, because then the result false positive results would come. That is a skin test. The problem with Mantoux is it is a non-specific test, that it is using the BCG antigen. So it may come positive with any type of mycobacteria which shares the antigenic similarity with MTB. So it will come positive with bovis, it will come positive with Africanum, everything. So it is a very non-specific test. Now this has been replaced by the CTB test, or we can say the Copenhagen TB test. Now the advantage of Copenhagen or CTB test is the antigen which is used in this test is specific for Mycobacterium tuberculosis. So there are antigens of Mycobacterium TB like CFP10 and ESAT6 which are used in this test. The method is same. It is given intradermally, 0.1 ml into the flexor aspect. The reading, the cutoff value, like for Mantoux, we used to use 10 TU. In CTB, we are using 5 TU as a cutoff test. And this is similar again to IGRA. This CTB is a skin test or a cutaneous hypersensitivity test. IGRA is a blood-based test. That means we take out 5 to 7 ml of blood sample and we process it for the activated lymphocytes, because the lymphocytes which are exposed to the mycobacterial antigens, again the same antigens, that is ESAT6, CFP10 and TB7.7. So these activated lymphocytes release specific interferon gamma, and these interferon gamma are picked up by a blood test. So IGRA is a blood-based test. The problem with IGRA is because it is a blood-based test, it requires stringent quality control. The sample has to be processed within 8 to 24 hours. It requires a lab setup. Okay, and you get so all these things are there, which is not there with CTB test. So it is a simple test like Mantoux test. However, the interpretation of both is same. If any of this test is positive, it indicates that the child is infected with TB. It does not say that it is an active disease, so it is for TB infection. One exception is if we see a recent converter. For example, we get a 10 or 11-year-old child, maybe who had received a Mantoux test previously, or who had done TB screening, previously, say when he was 4-year-old or 5-year-old, that time he was negative. Now, after 2-3 years, due to some reason or maybe symptomatology suggestive of TB, a CTB or a IGRA was done and it is highly positive. So that means that patient or child is a recent converter. That is a place where we must actively look for active TB, because the child has converted recently. So basically, the take-home message for these two tests is, if we want to detect latent tuberculosis or TB infection in the contacts of an index case, these tests are used.
Not for diagnosis of disease at all.
Not for diagnosis of disease.
So is there any change in recommendation from WHO about use of IGRA, apart from looking at the infection, TB infection?
No. IGRA is only for infection. They don't recommend it for active disease at all.
And what about this CTB? We are hearing about it over last 2 years. It is still not available in market. What's the problem? When it is said to be better?
On 24th March this year, the program has finally launched the test in India. I was there in Delhi for the meeting. So they have launched the cutaneous Copenhagen TB test, but right now they are running it as a pilot in 5 states. Okay, over the period of next maybe year end, they will roll out the test throughout the country. So right now they are
available for private practitioners as well.
Yes. So they have started.
It seems to be better.
Yeah.
So coming now to treatment, what are the important changes, Dr. Sushant, in the current recommendation, revised NTEP as well as the WHO one?
So NTEP is very clear. NTEP says that any child or adolescent with drug-sensitive tuberculosis has to get a 6 months treatment. That is 2 months of intensive phase and 4 months of continuation phase. The intensive phase has 4 drugs, HRZE, and the continuation phase has 3 drugs, HRE, isoniazid, rifampicin, and ethambutol. If we are encountering a neuro TB or a spinal tuberculosis, that is pot spine, in those cases, we can give a 12 months of therapy. That is, the continuation phase goes on for 10 months instead of the 4 months therapy. That is what NTEP says. Another thing what NTEP says is the old categories which we had, they are all out. We have only now 2 treatment regimens, one for DSTB or drug sensitive TB and another for DRTB, that is drug resistant TB, which means if we have a patient who has got a recurrence of disease, if the patient is a defaulter, now the terminology of defaulter has changed to loss to follow-up, or if the patient is a treatment failure patient, we reinvestigate these patients for active TB. And if we get a microbiology positive showing a drug sensitive TB, they again go on the same 6 months of therapy. So the initial cat 1, cat 2, everything is gone. So this is as far as NTP is concerned.
Only resistant or sensitive TB. The
Yes,
only target is either sensitive or resistant.
Or resistant. So
Yes.
this is what is followed, and it will be followed for quite some time as far as our guidelines, Indian guidelines are concerned, that is NTP. The WHO, which the guidelines which came up this week, they have incorporated a short course of therapy for drug sensitive. That is a selected category of patients with drug sensitive. That means if there is a single peripheral lymph node, or there is an intrathoracic lymph node without an airway compression, or only a lobar consolidation without cavity, without any associated pleural effusion, then in such cases, now WHO has come up with a recommendation that you can give a 4 months of therapy. That is 2 months of intensive phase and 2 months of continuation phase. But again, though it is a strong recommendation, they say that the countries have to see what is the prevalence or incidence at their respective places and then incorporated this guideline. So at present, India is not advocating 4 months of therapy. It is still 6 months.
So the multicentric trial based on which this recommendation has been launched, our Bizai Medical College,
Yes.
that was one of the centers,
Yes.
and they had contributed a lot to this study.
Yes.
And so it's going to be a long time to see that actually 4-month short-term regimen to come in for practice for us. It's just a positive development which we can look up to, but there is definite time. So for time being, we'll assume that 6 months of therapy for any tuberculosis. But if you look at Sushant, the definition of non-severe TB, apart from the malaria and TBM, most of the pulmonary TB of pediatric age group belongs to the non-severe one, as said here. So is it likely that it is likely to be included in next some time?
No, not likely. I mean, because you know what happens is, even if we see a solitary node, we don't know how many multiple nodes are inside. When we see an X-ray, it is a 2-dimensional feature. Okay, so there may be other nodes at other places which are causing airway compression in the posterior aspect or the inferior aspect. We don't know that still. And that is why, you know, it is not recommended. And for every patient, we can't keep on doing a CT scan to confirm how extended is the disease. So right now they recommend 6 months of therapy.
So it is going to take a lot of time, or unless we have imaging facilities to the grassroots level, that doesn't seem to be likely. What about the non-severe TB? Again, they have said the standard 6 months. So for us, now it remains 6 months.
6 months.
And what about this ethambutol first 2 months? In HIV and isoniazid resistance, does it apply? We are already having ethambutol in our regime. So it is not going to change anything.
It's not going to change. We are in fact having ethambutol even in the continuation phase.
So this recommendation is already included in our practice.
Yes.
This is not changed.
So we have already said about TB infection testing. What about TPT? There is a big change in TB infection concept and treatments. A lot has developed over last 3 years in this area, and now we have specific guidelines for NTP, how to pick up, how to diagnose TB infection, and how to treat it. Still, there are some gray areas depending on the availability of various therapeutic options. Can you guide us about that?
So TPT stands for TB preventive therapy. So till now, we had preventive therapy only for contacts of drug sensitive patients. Now we have preventive therapy for contacts of both drug sensitive as well as drug resistant TB patients. So what now the guidelines say is, if there is an index case of pulmonary TB in the family, so pulmonary TB, it could be any TB, it could be a drug sensitive or drug resistant. If it is a pulmonary TB, whether the patient is sputum positive or not, all the household contacts have to be screened for active TB. Active TB is by symptom screening, and if symptoms are positive, we do a X-ray and all the further tests to look for active TB. When we do the symptom screening and they do not have any symptoms of TB or there is no evidence of active TB, all the household contacts of this pulmonary TB patient are candidates for getting a preventive therapy. So initially it was less than 5 years or up to 5 to 18 years. Now all that has gone. Any patient, even if it is a 5-year-old kid, he is an adolescent of 14 years, or even if it is a adult of 50 years, all the patients who are in contact with the index case are eligible to get preventive therapy. What they recommend for children above 5 years is So below 5 years, they say you do a symptom screen. If there is no active TB, you start the patient on preventive therapy. Above 5 years, that is 5 years, beyond 5 years, and in adults, they say if we have the facilities. So it is a disclaimer. If we have the facilities, we do testing for TB infection. That is, we either do a TST or we do a IGRA test. And if it is positive, it gives us an additional hand to counsel the patients to take preventive therapy and complete it. Because what is the general thing in the patients is, if I don't have disease, why should I take treatment? That is one thing. So if we have an objective evidence ki, look, your IGRA is positive, that means you are exposed to infection. If you take this one tablet for say 3 to 4 months or 6 months, it is likely that you will not develop active disease. So the patients are better convinced and they stick to the therapy. Less than 5 years, why they don't recommend this is because if we see up to less than 5 years, if the child has contracted infection, the chance of him going into an active disease is as high as 25 to 30%. So they don't want to take a chance. They say that up to 5 years, if there is a contact, if active disease is ruled out, we give prophylactic therapy to all these patients. So the guidelines are now very simple. If there is an index patient of pulmonary TB, screen all the household contacts. If there is no active TB, put all of them on preventive therapy. Now, what preventive therapy to be given? Till now, we only had 6 months of isoniazid therapy. So we had to take daily isoniazid for a period of 6 months. Now, another one, which is again made available free of cost through the program, is 3 months of HR, which is isoniazid and rifampicin. Now, the advantage of this therapy is this tablet is a combination tablet and it has to be taken only once a week. So the patient does not have to take daily therapy. So once a week has to be taken for 3 months. So that is 12 weeks of therapy and it is done. So that is a very big step or big advantage. The compliance of patients is much better as far as 3HR is concerned. The only thing is it can be given for patients 2 years of age and above, because less than 2 years, rifampicin is not, the safety studies are not there. So up till 2 years, we still have only one option of 6 months of isoniazid, but above 2 years, depending upon the patient or depending upon their choice, we can give either 6 months of isoniazid or 3 months of isoniazid and rifampicin. So this was for drug sensitive patients. As far as drug resistant TB is concerned, if the pulmonary TB index patient has a drug resistant tuberculosis and he has to be he should be a case of only MDR TB. That is, he should not have any additional resistance to fluoroquinolones, any additional resistance to any other second line drugs. So if that patient is a pure case of MDR TB, then again, the contacts of these patients are eligible to getting preventive therapy. And here the preventive therapy which is recommended is 6 months of levofloxacin. Again, we have to rule out active disease and we give 6 months of levofloxacin. The third category is isoniazid monoresistant TB patients. So we have around 20 to 22% of the Indian population who is having monoresistance to isoniazid. So again, if we have a pulmonary TB patient who is an isoniazid monoresistant patient, we screen the contacts. If there is no active disease in the contact, all these contacts can be given 4 months of rifampicin. So these are the 3 varieties which are now available as far as TPT is concerned. One for drug sensitive TB, second for MDR TB contacts, and third is for H monoresistant TB contacts. It has to be a pulmonary TB.
So that was quite clear. Dr. Mankar, but for a practicing pediatrician,
Yes.
the very important question is when to suspect DRTB. Because all the therapeutic options, all the algorithms depend on the category. If you are suspecting DRTB, then the total path is totally different. So when to suspect DRTB in practice?
So most of the time the DRTB will be suspected when the contact, that is the index case itself, is a DRTB, and the child who is coming in the contact with the index case who is a DRTB is more likely to be a drug resistant tuberculosis only. Second, when the child who has been diagnosed as tuberculosis on the presumptive diagnosis therapy, and when you start treating and there is no response to the therapy after say around 4 to 6 weeks, it is more likely to be. Or if there are the worsening of the symptoms and there is no iris-like phenomenon, then it is more likely to be a drug-resistant tuberculosis. And of course, when your gene expert shows that it is a resistant tuberculosis, you need to label it as a drug-resistant. And the child who is coming with a recurrent or defaulter as a tuberculosis, he has treated in past and the second time the attack has occurred, then it is more likely to be a drug resistant tuberculosis.
So that's very important, very clearly said. If you suspect DRTB, it is not your game, and it has to be referred to confirmation or a diagnosis, because there you can't afford to half treat or half diagnose. The resistant TB is a totally different ball game. It is under the care and under the domains of an expert, which is usually the local tuberculosis unit, government tuberculosis unit. Because in private also, let me tell you, most of the senior most experts do not have much experience or the current updates about the DRTB changes. So let's leave the DRTB issue to the genuine experts and those who are authoritative and who are doing it regularly. Again, the availability of bedaquiline and delaminate other agents, it is not still available in private market. Dr. Sushant, my personal experience about the standard tuberculosis therapy, last 3.5 years, I have not prescribed a single drug for the chemist. All my patients I have sent to government agency and they are so happy. I always appeal all the pediatric practitioners to do this because it's so convenient, so easy, and so beneficial for everybody. There is no headache for you. And the important aspect, they can deliver you the medications at your doorstep or patient's doorstep to be delivered. So, Sanjay, what is your experience about this? Because many of our colleagues still keep on writing those funny combinations which are most unscientific to this date, and they keep on asking what is the current combination available in the chemist shop. Let me tell you, there is nothing. FDC is government is the only reliable and highly reliable source for FDC. Sanjay, your experience about that?
Yes, definitely. We also do send patient to a government center. We have a lot of this thing. If you remember, opposite the Mitra Mandal, there is a Thakre hospital, which gives all kind of drug free of cost to all these things. They trace the contacts also. They give the drug free of cost, and they can deliver even at home. And they have got a good fixed dose combinations also. And their MOs are trained for the particular weight. They are giving typical 1 tablet, 2 tablets, 3 tablets, depending upon the. So the chances of having mismatched doses or mismatched combinations are very less. And in private practice, we don't have that much amount of a good combination. Sometimes you will give those, the INH may fall less, or even rifampicin may fall more. So not a very good rational combinations are there. So it is better to send to a government setup, and they will give you a proper this thing free of cost. Yes.
They have made it so simple for a health worker also to dispense the anti-tubercular drug. So the weight bands are very easy to remember. 5 kg, 10 kg, 15 kg, 20 kg, 25, 30 and more than 30. Very simple, only 2 formulations, a pediatric tablet, adult tablet, and only ETB is the separate tablet. It's very easy to remember also, no jugglery of weight-based calculation, and it's very convenient for a prescription as well. And what I personally do, I prescribe the same formulation, government FDC formulation on my prescription to be taken up by the government, a person who is taking care of the supply as well as follow-up of this child. And the patients also get advantage and benefit of some nutrition, health support from the government, regular registration, completion and compliance, everything is fine. So I will urge and request all my pediatric colleagues to go for this very easy way of treating our patients appropriately and completely with win-win situation for us as well as the government as well as the patient. What is your take on this, Dr. Bane?
Yeah, absolutely. I think, sir, people should clap for you. Being in private practice, you are sending patients to a DT, what you can say, dot center. And I think that message should go, as you said, that we don't have to use our brains at all. It is so simple. Another thing, what in addition, I might suggest is sometimes patients are not comfortable going to a dot center. Sometimes, if you counsel, then it is the job is done, but sometimes they are not comfortable enough going to a public hospital or a government center to get medications. The program also gives the privilege to the practicing pediatrician that the drugs can be kept at his or her own clinic. Okay, so we all of us have a helper in the clinic. We have an assistant in the clinic who can take care of this. We just have to maintain a record for 6 months and then hand it over back to the program. Once we report a case to the program, we just call up the local DTO, that is the district TB officer. And if we tell that this patient wants to take treatment only in my clinic, he does not want to go to a dot center for getting his drugs, the program person will come to your clinic with the 6 months course of the medications. You can keep the medications with you and you can dispense every weekly or every 2 weeks. So even that is allowed. And every 2 weeks or 3 weeks, the program person will come and take the record how many tablets are consumed and how is the patient doing. So we don't have to do anything. We have to just sit down in our clinic and dispense the medicines. So even that option is there.
Why our private industry, pharma industry is not going after these FDCs? They are not available on counter. Actually, if they are, then the private pediatricians might be more encouraged to write those.
So there are preparations which are available over the counter, I mean on a doctor's prescription, but those, what happens in those combination is either they are H and R combinations or H, R and Z combinations. And if you see the strength of medications which is there, it is not rationalized. Like if we calculate the milligram per kg dose of isoniazid, it would come proper. And then when we apply it to the milligram per kg dose of rifampicin, the dose would be a problem.
No, Sushant, I'm saying about the government FDCs. Similar one, why they are not being brought up?
Government are not giving it. That is what government thinking is. They are not giving it over the counter to the medical shops is because then they don't have a record. Because there are still certain category of patients, because of the social stigma, they are not reporting. So they will just go to the medical store, take the medicines and go home. There won't be any accountability and there won't be any report. I mean, the reporting will be hampered. That is why through the program which is available, they say that just register in the program. We will give it to you at your doorstep, but come to the program.
So it is least likely that this will be available for us direct OTC purchase anytime in near future. So otherwise also we are bound to send the patient for government FDCs.
Yes. So that is what I said. Even if you don't send the patient, even if we just call the district TB officer, he will get the medicines and everything at your clinic. So the patient does not have to go anywhere. He still comes only to you.
Let me express my appreciation toward the PMC people here. They are so cooperative. They collect the samples in time. They contact the patients, register everything on our behalf. They supply the medications. If there are any issues, they are of great help to the patients. So they are very, very reliable people.
So this is what a field experience you're talking about, sir. I attend the WHO meetings. There are 19 member nations which are reporting high TB cases. India is obviously number one in that. But let me tell you, the NTP program of India is one of the best in all these nations. The amount of infrastructure which we have, the reporting system, Nikshay which we have. Nikshay has everything, right from diagnosis to side effects, everything. Then all these incentive schemes, that is nutrition yojana, and even incentives to the reporting people, doctor and all. Hardly any country's program has all these intensives. India's NTP is one of the best programs across the world.
One more last point about the punitive side of this. Non-compliance within in near future. Provision.
Sir, please ask question again.
Yeah.
You are not audible. Kulkarni sir.
त्यांचा टेक्निकल इश्यू काहीतरी झाला.
Sir, Mane sir, he was asking about side effects and all.
Side effects of medicine.
Yeah.
Side effects what?
Ha sir, he is online. Ha Kulkarni sir. Unmute sir. Unmute.
With this, let us conclude the session. I will request Dr. Sushant, the utmost ultimate authority in this field, and Dr. Mankar to have their concluding comments. And if Dr. Vijay is there, his valuable input.
Yes. Vijay sir is there.
Pramod, can I make a comment? The very commonly asked query from pediatrician is, if they see a patient with cervical lymphadenopathy, should the contact be treated for preventive TB? Sushant, is there any change in the guideline?
So guidelines are very clear. Only if there is a pulmonary TB, we treat the contact. Extra pulmonary right now we are not treating.
And regardless of sputum status.
Yes, regardless of sputum status.
And the hilar and mediastinal lymphadenopathy is treated as pulmonary TB.
Yes, yes.
So that one needs to make a note of. And again, talking about the program, Pramod, I totally agree with you. In our private practice, we have a double advantage. I practice in Navi Mumbai, where municipal corporation has an FRU. At FRU, there is a TB center. So all our patients, even good quality class patients, are referred there. We get the gene expert report, we get the treatment. And then we have at a phone call away, Sushant Mane for us. All our DRTB patients go to JJ Hospital. And let me tell you, Sushant has been of such a great help to us. And in our place, we treat DRTB, and it is only, trust me, unless you start treating DRTB, you will not know to treat DRTB. And unless you treat DRTB, you should not, take up on treating DRTB. It's a very huge task, and it's not very easy. It's not, unless you treat, you should not, and develop confidence, you should not do it. You should refer such patients to DRTB centers.
Kulkarni sir, there are 2 questions in chat box. Can you ask?
पराग तूच घे, सरांचा टेक्निकल प्रॉब्लेम येतोय काहीतरी.
आहेत सर.
हा, पण टेक्निकल प्रॉब्लेम येतोय बहुतेक.
तू घे पराग.
Okay. Sir, one question is, how much and how long should we supplement pyridoxine? Mane sir.
Pyridoxine, as till the time patient is on anti-TB drugs, we have to give pyridoxine. So if it is a drug sensitive TB, we give anywhere between 10 to 20 milligram per day. And if it is a drug resistant TB, it is 50 to 100 milligram per day. But till the time the patient is on treatment, we give pyridoxine daily.
Okay, sir. Thank you. And one question is, what about Mantu test or IGRA? When to use?
That we have said.
Repeat.
TB infection. We have to use only them.
Okay.
So Dr. Mankar, your
sir.
inputs, please.
Sushant, can I take this opportunity to ask you a question?
Yes, sir.
Yes.
When I was doing my residency, there used to be a practice of testing every new registration. Any pediatric patient coming to pediatric OPD used to get a Mantu test.
Yes.
And that was in 1970s, late 1970s, or early 80s. And then we stopped that trend. Now today we have extended TPT to all contacts, household, regardless of the age. Now, if you really want to eliminate TB, it is, there are pros and cons of treating latent TB in every patient. We do treat latent TB if there is an index case. However, was this discussed in WHO meeting that in countries with huge TB burden, one should start now proactively looking for latent TB and start giving prophylaxis to them after active disease. So should we switch over to that old practice of testing every new patient who comes to pediatric OPD with a Mantu?
So that is again a gray zone, sir. Because if we see, program has actually started giving latent TB treatment, but if we see the experts, they are again in two minds, because we have so much amount of latent TB and we don't know how much amount of latent TB is actually active TB. We are not doing that. So when WHO said that, screen for latent TB and start giving treatment, they actually meant for areas of regions which had a low prevalence of TB. In India, the problem is we have a very high prevalence of active disease only. So this therapy is actually very skeptical. If this has started in 2019-20, maybe in the next 5 years till 2023-24, we'll get a picture how much this has been successful, the TB preventive therapy.
And again, the emergence of DRTB with monotherapy.
Yes, because the thing, that is not, the literature which is published, that does not say that, if we give monotherapy, it would cause resistance to that drug. But again, whatever literature is there and whatever evidence is there, that has been all focused on low prevalence countries. India being a very high prevalence country, for example, if I want to give you, now we have started, I should not be talking this as a program person, but still, because this is an academic discussion, I'll tell you, we are, giving 6 months of levofloxacin to contacts of a MDR TB patient. Now, if we see the background resistance to quinolones in India is 42%. So again, that is a big, worry. What will happen? So, they have started it since 1.5 years. Maybe in another 1.5 to 2 years, when we get all these data of patients who were actually put on TPT and how many of them actually went ahead and developed an active disease, and out of those how many actually were resistant to levofloxacin, it will take time.
Another question that I have, Sushant, is in program. In some places, the second line LP is made available. Is that so? Do you have
second line LP as in?
LP and for sputum positive cases or on isolates? What is the availability of LPA, first and second line?
So if it is a sputum sample, LP, I mean, sputum is positive, LPA is done for all patients. If so, the guide.
So is it available widely now?
Yes. So if the gene expert has a rifampicin sensitive report, and if the sputum smear is positive, only first line LPA is done to check for H mono resistance. And if the gene expert says that it is a rifampicin resistant sample, then both the LPAs are done, first line as well as second line, immediately.
And there is a test which is making rounds in private sector, where on expert platform they look at resistance to other drugs.
XDR POCT.
Expert XDR. Yeah. Expert
So
XDR. Expert XDR, right?
Validated.
Yeah, it's validated by WHO. It's given a go ahead by WHO. India it is only being done in Delhi right now. Expert XDR, that too under operational research. PRD is doing expert XDR. And we are planning to start it in JJ again as a research platform.
Unmute kar, Parag.
Sir, when to do LFT for monitoring for the side effects?
So we don't have to do routine LFTs for monitoring, only if the patient is symptomatic. Like if patient develops symptoms suggestive of hepatitis like vomiting, nausea, anorexia, or the patient is having visible icterus, then only we do a LFT and see. Because see, all the drugs which we use for drug sensitive TB, HRZE, out of these 3 drugs are hepatotoxic: isoniazid, rifampicin, and pyrazine. If on doing LFTs, we are never going to get a normal LFT. So once we start anti-tuberculosis drug, if we happen to do a LFT at 1 month, suppose the upper level or cutoff level is 40 IU of our SGOT, SGPT, these patients have enzymes in the range of 65, 70 or 80, something like that. That does not mean that their liver is damaged or the liver is, it is going to cause a problem. So that is why routine LFTs are not to be done, because then people tend to withhold drugs. So only if the patient has symptoms, signs and symptoms suggestive of hepatitis, we do a LFT. If the enzymes are raised more than 5 times the upper limit of normal, then we stop the drugs.
Okay. Sir, one more. How to clinically differentiate worsening from paradoxical reaction?
Worsening from, so paradoxical reaction, as is always said, it is a diagnosis of exclusion. So it cannot be our first diagnosis. So if the patient is, suppose if we start the patient today on treatment for drug sensitive TB, pulmonary TB, and after 2 months, the patient comes with increased fever, pleural effusion, and something like that. First, what we suspect is a worsening or a DRTB. We repeat the test of the patient. We do a gene expert again. We see the X-ray. We do all the tests. If everything is negative, okay, and it is not fitting into an active disease, or if the patient has gained weight over the period of time, after excluding all these things, then we can label that the patient is having a paradoxical reaction on itis. It cannot be the first diagnosis.
Yes. So last question. Can we send the patients of suspected pulmonary tuberculosis for gene expert to TB treatment centers? Okay.
So treatment center, if it is only a dot center which gives drugs, they won't be able to do it. But yes, if it is a government or a PMC hospital, yes, definitely they will be able to do diagnostic also.
So in Pune, we do have this facility. We will provide on IAP WhatsApp group the contact number of the person who are responsible for entertaining your call, coming for collection of specimen, giving back you the reports, calling you back with the reports, as well as the treatment facility. So we have many people in Pune, and the cooperation is very nice. We will provide you those numbers.
Okay, many questions are there, sir. Two question. Can we ask or should we conclude? Kulkarni sir?
I think we should conclude.
Okay. Okay, we will send. We will send at mail.
We will answer all those questions personally.
Okay. Well, please make a note, Kulkarni sir. Mankar sir, last comment. He left, I think. So thank you. Thank you, Kulkarni sir. That was a wonderful session, very interactive. Thank you very much,
Thanks,
Dr.
Dr.
Sushant Mane.
Mane.
Yeah.
Was the absolute limelight of this presentation. Thank you so much.
Yes. Yes. Thank you, Mankar sir, to give pediatrician perspective, practicing pediatrician perspective. And lastly, thank you, Dr. Yevele sir, for your time in your busy schedule. So Kulkarni sir, hats off to you. Finally, I also thank Dr. Deepak Moye, Secretary of Pune IAP. Thank you all. Thank you.
Thank you, Dr. Vijay, for giving your time. Thank you so much. Thank you, Sushant. Thank you very much.
Thank you. Thank you, sir. Thank you.
Really wonderful session. Kulkarni sir, hats off to you.
Thank you.
Yeah.
Thank you.
Mankar sir, thank you. Later.
Thank you. Thank you all.
Thank you, Sanjay.
Thank you.
Mankar sir, thank you.
I was slightly away in between, but thank you all.
Thank you, sir. Thank you.
Thank you.
Piyush, we will declare as a end the session.
All right, sir. Thank you.
एकच मिनिट हे क्वेश्चनचे फोटो काढून ठेवतो.
हो हो.
ओके चलो थँक्यू.
All right, sir.